Hospital. This is Joey with Logan County EMS.
Logan Hospital, go ahead.
So I'm calling to activate a trauma team. We're en route to you with a 12-year-old male who was an unrestrained front seat passenger before his vehicle rolled at highway speeds. The patient was ejected and found approximately 30 feet from the vehicle. When we arrived, the patient responded only to pain by withdrawing and utilized inappropriate words. So we don't have much information on him. We initially noted diminished lung sounds from the right, and he had a respiratory rate of about 60 that was labored, and his skin was pale and cool. He has abrasions to the right side of his face, both arms, abdomen, and back. He has a laceration to his bicep, upper right quadrant, and left leg. There's a 4-inch hematoma on the base of his rib cage on the left, and his pelvis is unstable. We're attempting to assist his ventilation with a BVN, but he's resisting. We did do a needle decompression of the right side of the chest, but only got a little air. But his respiratory rate has since decreased to 24. We placed a small IV catheter, but it's positional. We have a pelvic splint on him. Current vitals, blood pressure 191 over 47, heart rate of 150, respiratory rate of 24. We can't get an O2 set, and we'll be there in 5 minutes. Any questions or orders?
Negative, see you on arrival.
All right, so it sounds like we got a 12-year-old male come in. Sounds like he's going to be shipped out from here. So if we could please get St. Vincent's on the telemedicine, and we'll tell him what's coming and see what we need to do from there.
All right, everybody would get their BSE on, and we're going to warm the room up to 80 degrees. You want to call St. V's, ask him to get the doc in the telemed room, and put the helicopter on standby, please.
Yeah, sounds good.
If it's available.
Perfect. And Brent, could I
Trauma
have you
team
doing
pause.
Broslow?
For the provider to initiate telemedicine consultation with our service, they have to go through 3 separate steps. These steps ensure that the patient receives the correct provider consultation and that they are registered in our electronic health record for immediate documentation, so the record's immediately available back to you. The provider will use the same triage criteria for telemedicine patients as they do for our acute in-house patients. The reason we do this is it ensures that the most acute patients are always seen first. So your patients are triaged into our system the same as our patients are. The requesting facility faxes demographics and pertinent records to the fax number. We have a tip sheet that accompanies all of our mobile carts. The fax will generate a registration to the EHR. A call is then made to a number on the tip sheet where a call center determines who should be seeing the patient. Do we need an ED physician? Do we need a pediatric intensivist? Or a neurologist in the case of a neurological emergency or stroke? In this case, the patient will be seen by the ED physician, so the call will be transferred to the ED nurse's station. The rural ED has now entered their assigned virtual waiting room from their cart, and they will wait for the ED physician to join the call from their location. Trauma team resume.
So Brent, could I have you do Broslow tape, please? Get that ready.
Get ready for monitor.
Monitor, please. And when you get ready, we get into definitive IV access first.
Sure.
And draw labs as well, please.
Good.
Hey guys, this is Dr. Lammers.
Hi, Dr. Lammers. This is Dr. Payton up at Logan County. How are you, sir?
I'm doing well. What do you got going on?
I have a 12-year-old male who's involved in an MVA approximately 60 miles an hour. He was unrestrained, thrown 30 feet from the vehicle. He has multiple traumas, including what seems to be a fractured pelvis. He has decreased breath sounds on the left with a large hematoma over the left flank. He has a needle in his right lung, which did decrease his respirations from 60 to 24. He is currently vitally unstable with a BP of 91 over 47, heart rate of 150, and respiratory rate of 24. They were unable to intubate in the field given resistance, and I'm thinking we're going to have to do RSI on him. I just haven't had the opportunity to do RSI on a 12-year-old recently, so would love your help on that, sir.
Yeah, of course. So kind of going through our ABCDEs here. Airway sounds like we need to address that first. Do we have a weight or a Broslow
You're Broslow green.
category on him?
We're a Broslow Green, Dr. Lammers.
Okay. And you walk me through what you're doing, and you tell me when you need something.
Okay.
I'm following you close. I've got all the answers here, but I don't want to give you things
Sure.
that you don't need. So you walk me through what you're doing, and I'll help you along the way.
Okay.
So we have
We do have him
positional
hooked.
access.
Yep. And
So-
we do have him hooked up on the monitor now.
Okay, so we currently have him hooked up on the monitor. His blood pressure currently is 70/45 with a heart rate of 130. His respiratory rate is 18. How's the bagging going, Brent?
It's difficult.
He's
And do we have fluids going on him?
We have a positional 22 gauge, but I think we could use it to RSI and then probably look at another site or possibly drill this kid.
Okay, perfect. So let's go ahead and use, for our equipment here, we're going to use a 6.5 cuff tube. And then what do we have for other airway equipment there?
We have everything here. We have a King airway, we've got blade scopes, all the conventional stuff, and the King airway is a rescue airway.
And Dr. Payne, do you feel more comfortable with direct visualization or with a gyroscope?
We have suction available.
direct visualization.
Okay, so let's go ahead and do that then. And why don't you grab either your Mac or your Miller, whichever one you feel most comfortable with. With his size, he's probably going to be a 2 for the size. And then you've got your tube there. And do we have the ventilator and
We have just the
everything
DVM.
eventually?
We have no respiratory available yet.
Okay. And then for medications, let's go ahead and do etomidate and then succinylcholine, choline, and let's do just a little bit of atropine on him as well. So for the atropine, what we'll need is 0.5 milligrams. For the etomidate, we're going to need 10 milligrams. And then for our succinylcholine, just verifying the dose here.
Joey, you want to set up to drill this kid? We've got all our
Get the
vitals
line.
here.
We'll be right at it's giving us 66 milligrams, so we can round up or down just a little bit as needed there. Let me know when the medications are ready.
Etomidate first.
Okay.
Say the etomidate again, Dr. Lammers.
Say that again, I'm sorry.
Dose on the etomidate.
10 milligrams.
10 milligrams, okay. How are our vitals doing? Are we maintaining?
You got cut off just at the beginning there. What was your question about etomidate?
We were just verifying the dose, but Ryan had it here. He scribed it down. So 10 milligrams.
And do you all have a Broslow tape next to him?
Yes.
do.
Yes.
Okay, perfect. And then, Dr. Payton, for your backups here, let's say because he is in C-spine precautions here, if you don't have a good look direct, let's make sure that we've got the kaleidoscope powered on with the right stuff attached onto it, and then also let's have a bougie on backup as well, just for our triple backup.
Right there.
We have a bougie, but we do not have a glide scope at this hospital.
Okay, all right. So our bougie will be our backup. And does it feel like he's bagging pretty well?
We just got did we get the etomidate in yet?
Etomidate is ready. Are we ready to push drugs? Everyone's ready?
Yes.
Bagging hasn't changed.
Okay.
We're ready with drugs now.
Okay.
Okay.
We have new
So
vitals.
let's go ahead and push the atropine and the sucks. And then after those are pushed, we can just push the etomidate right after that. And we've
Recent
got
vitals.
suction and all the rest of our stuff set up.
So-
there.
Suction is ready.
Suction is
Okay,
ready.
Perfect.
His blood pressure is now decreased to 51/41. Heart rate is up to 160.
Okay. So let's get him intubated here.
Okay, so
I still have EMS here.
Atropine.
I'm gonna have them place an IO.
Perfect.
atropine
And then
is
let's
in.
also have EMS work on a second peripheral IV, but let's definitely get that IO going.
Atropine is in.
Our room's at 80 degrees, so we can uncover this kid and get everything
Start
off
looking
of
at
him.
things.
Everything else. I agree.
Okay. Sucks is
All right,
in.
let's go ahead and intubate.
When you're ready to accommodate. Okay. Accommodate is in.
Dr. Payne, just kind of walk me through what you're seeing there.
So what I am visualizing right now the vocal cords, there's no swelling, there's no trauma to the inside of the throat as far as I'm seeing.
Awesome.
Do you have blood pressure? Grab your syringe. Okay.
And a 6'5" tube, we should be about 18
And then let's go
or
ahead
20
and start
feet.
bagging him. We'll put the
There's a detector on the,
CO2 changer on there.
there's a changer
And
right
Dr.
there.
Payne, let's go ahead and listen for breath sounds as we're starting to bag there.
Got a positive marrow return on the IO.
IO's
Possibly
placed.
Pink IO on the right.
So-
tibia.
Do we have good colorimetric change?
Checking that now.
Checking it right now.
Okay. Dr.
Good
Payne, what
change.
do his breath sounds sound like?
Positive change.
So there are diminished breath sounds on the left. On the right there is increased breath sounds as compared to left.
Okay. Are you seeing decreased in chest rise or anything on that left side where you've got decreased breath sounds?
Yes.
So, in terms of we've got our airway secure now, let's move on to our breathing, and I think that's where our next hurdle is here. It sounds like he was needled in the field, had some initial improvement, but is kind of starting to decompensate again. My concern would be for a potential tension pneumo. So, do we have x-ray capabilities?
We have x-ray on
Yes.
standby.
Okay, let's go ahead and get a quick chest x-ray, and in the meantime, let's deal with his circulation. It sounds like his blood pressures are going down. What would you like to give him at this point, Dr. Payton?
Well, I would like to give him a
Set it up on
fluid bolus to him, 1,000 cc's of either lactated ringers or normal saline, either
Well,
one
he's
will
only a little kiddo, so we can,
do. So, normal
Couple
So
saline,
let's do, let's do
boluses,
an initial 20
20 cc's per
mLs per
kilogram.
kilogram bolus, and we can push that through on the IV or through the IO. And let's make sure we've got a pressure bag on that as well. And if we've got a good change in his vital signs, then we'll stick with the initial 20. But if not, I would like a second 20 mLs per kilogram push through the IO.
should we go to the lab and get blood? Are we gonna need blood?
Yes.
I don't see a pressure bag in here. It'll have to be
Oh, we
me.
have a pressure bag. We
I got
have
one.
a blood pressure cuff.
I'll make do.
And let me know when our x-ray's ready.
Let's put this 20 or something.
Yep.
All right, we got an updated vitals.
And then, can one of you run to the lab and get the uncrossed matched blood?
Trauma team pause. Please note the actual time to complete lab and imaging studies will vary based on your facility. Once the images and results are obtained, the consult can be continued. Trauma team resume.
In the meantime, while we're waiting for that x-ray, have we drawn blood on this patient?
We got some blood off of the IO.
Okay, we'll go ahead and send off what we can for our trauma panel. It's clear that this isn't the definitive location for this patient, but we'll do due diligence here and send off the initial trauma panel. Do we have our x-ray back yet?
Not yet. Our vitals are improving. His blood pressure's up to 86 over 54 now. Now the
X-rays up.
x-ray is up. And he does,
And what do you see it? And you can move the iPad there for me, and if I can pick it up there. So what do you think's going on there?
he has a pneumothorax on the right.
Yeah, so he's got a very large pneumothorax, and it looks like he's got shift to the left. So this is clearly a tension pneumo, and we need to take care of this immediately. So let's go ahead and prepare for a chest tube.
Okay.
First IV bolus is in. What is our vital signs sitting at?
We got blood pressure 86 over 54, heart rate 154, 153, resting respiration 24, temps 94.1.
Sats
O2
are
sats are 88%.
Okay, so we've had a decrease on that.
So we're gonna need some pain control and a little sedation on this kiddo as well. So let's go ahead and give him, by weight, we're probably between 30 and 40 milligrams of fentanyl. What was his last blood pressure?
86 over 54.
Okay. So let's go ahead and do 35 milligrams of fentanyl as we're preparing to put in this chest tube, and then just keep me apprised of his vital signs as we're going through this procedure. If it seems like he's, getting more tachycardic and more hypertensive, let's address pain control during the procedure.
Julie, you want to grab our bedside table and bring it over here so
Yeah.
we can set up supplies for the test tube, please?
Okay, giving fentanyl now.
Dr. Lammers, we also requested help flight on standby. You want to see if they're still available in launch stand, please?
Yeah, let's have them ready to transport. We'll be the accepting facility, and I can be the accepting provider.
You said you wanted another line?
And again, Dr. Pate, we'll treat this just like the intubation. I don't want to be hovering over you too much or distracting you too much, so you walk me through what you're doing, and any questions you have, feel free to ask me, and we'll walk through this together.
We have more vital signs.
Yeah, our new vital signs are blood pressure 74 over 51, heart rate 156, resting respirations 21, temperature 99.1, and oxygen sat 91%.
Was that 91%?
Yup, increased from 88%.
Bagging is still difficult.
Yes, we have a tube that's ready, and I have the chamber set up. And suction.
As Dr. Payton is setting up there, if we have potentially one of the first responders can kind of help me go through the rest of a primary survey with him as Dr. Payton's getting set up. Any other obvious trauma to the chest?
Jackie, you want to handle that? No, Joey's getting the IV if you want to just
Okay,
walk Dr. Lammers through.
so
these
obvious
questions.
trauma to the chest, we're seeing abrasions. Left side,
Looks like both upper
Both
quadrants
upper
have some
quadrants.
bruising and abrasions.
lower quadrant, left side, and right side, lower quadrant.
Is he distended at all in the abdomen?
No.
Or
No.
firm? No. I see that he's got a pelvic binder on.
He was
Yes,
unstable in the field. That was placed prior to arrival.
Okay. Distally on the lower extremities.
nothing obvious.
Okay. Does he have good distal pulses in the lower extremities?
And now that we've intubated, he's attention.
Oh, femur fracture, left side. Not splinted,
No pulse.
no pulse, left.
I'm gonna
Pulse on
seal
the
your
right.
table for the chest tube setup.
So we are cutting in and out just a little bit there. Good distal pulses bilaterally.
No.
No, right side only, femur fracture,
Right
left.
side only. Okay.
Okay.
And if we can move the iPad around a little bit so I've got a good view of what Dr. Payton is doing there.
There's a second 28 IV in the right forearm.
So we do have a second peripheral IV at this point.
Second 28
Correct.
IV in the right forearm.
Great.
That's in front of you.
Great job communicating, everybody. It's really helped me a lot with kind of the closed loop feedback and all the good communication, so I really appreciate that.
How's our vital signs look into our pressure?
Our new vitals
Same.
are 82/51, heart rate's 164, respiration's 21, temperature's 98.9, and O2's at 88%.
Make
So
sure.
Dr. Payton, he's kind of starting to downtrend a little bit
Yep.
here with his oxygenation.
Okay.
So kind of walk me through what you're doing, and let's get this chest tube in.
All right, so right now I am just preparing to anesthetize the skin, and then I will start.
And you can do just some fairly quick generalized just kind of infiltration around there. We've got pain medicine on board, and we'll help keep him comfortable here.
Okay.
So fluid-wise, what have we given him, Ryan?
Stuck 2 boluses
Yeah, we
in.
had one bolus.
One
Did you
bolus.
say another bolus?
Second bolus finish. And our,
Second bolus is finished,
Mhm.
okay?
We
and
do
our
have
pressure's low, so we have,
some O-neg blood. Should we start that or a third bolus or thoughts?
Let's see what his vital signs do. If we start to have another drop in his blood pressure at all, then he's gotten his 2 boluses, and let's go ahead and we'll do 1 unit of the ONEG.
Friends, if you have something else to do, I can squeeze the bag.
it is spiked and ready, so
Okay.
And he's on a trauma bed.
Mm-hmm.
Shoot a
we could do a quick pelvis x-ray.
pelvis. Yeah, from this
While we're
side.
waiting.
So I've inserted the needle, I've gotten good flashback, and I've been in it for so I'll go ahead. Size.
We have updated vitals, blood pressure 111/64, heart rate's 134, respirations are 21, temperature is 98.1, and oxygen stats 94%.
Once we're done with our procedures, we need to try to cover him back up and keep him warm, guys. Dr. Lammers, that's a 24 French chest tube.
Okay. Great.
And it looks like we're in.
Is there, I don't know if there's anyone who can move the iPad around so I can get a little bit of a better first person. But if
Yeah.
not, I understand.
Sorry.
Can you see?
Okay,
Yep.
are you ready
Yeah,
to
that's
hook up?
awesome.
You want to suture in first? And I can hook. Yep.
So Dr. Payton,
Okay.
make sure you've got that secured there at the base. You did an awesome job getting it in. I'd hate to have you redo it all if it slid
Gotcha.
out, so.
I've got a little bit if you want to suture.
Oh.
I think there was 2O in the kit.
So it looks like you've gone, in between second, third intercostal space there. Looks like good placement. He's had a good improvement in his oxygenation. So I think we've got it in the right spot. Why don't we'll get set up for the rad tech to shoot a second chest x-ray, as well as the pelvis film, as soon as we get this tube.
Somebody want to
Secure
listen to
here.
lung sounds real quick and just verify?
And then after we get that done, is there anything else that would potentially delay him getting to us?
No.
And we got that pelvis x-ray prior to the chest tube insertion. Is it back yet?
Okay.
Positive breath sounds on both sides, nothing over the epigastrium.
Great.
Bagging pretty easy now.
That's a lot better. Do you have a repeat chest x-ray now that our tube's in?
Dr. Lammers, can you see that pelvis x-ray? Or we can move it up a little closer if that doesn't work.
It's washed out a little bit, but he clearly has multiple fractures. And that binder we have sitting over the greater trocaners, it's not right and high or low on them.
It is.
Okay.
Place-
Yeah,
Placement is
placement is
good.
correct. Sure.
We are gonna have to start to get set up for
I'm just gonna
either
move forward.
gastric tube and Foley's and such once this is secure. If we have enough team members, we can check the back tubes I'd like to use here, huh?
So we've got a hemoglobin of 9 and 28. It looks like, we don't have a baseline for him, but he should otherwise healthy kiddo probably be, 15 and 45 at least. So let's go ahead and transfuse that one unit that we already have spiked. And we should probably give him some TXA as well.
So we should do some 10 milliliters of blood per kilo.
Do you want to give the whole unit or do you want it weight-based, Dr. Lammers?
Let's do weight-based.
Okay. He's agreeing to 36 kilos, so 360 mils of blood.
You said 360?
360 would be 10 per kilo. Thank you. I'll take that.
How are our vitals looking?
Current vitals, blood pressure 111 over 84, heart rate's 132, respiration's 20, temperature is 98.1, and oxygen saturation's 96%.
And how's his activity level? Does he seem to be fighting this at all?
There's no movement or response at this point. Sedation's still in place.
Okay.
There we go. Okay, so chest tube is secured. Did we get our repeat chest x-ray after that?
Yeah, let's get that repeat chest x-ray. Clinically it looks like it's been placed appropriately. We've got good vital signs and good breath sounds. So we'll get that repeat chest x-ray, and then it sounds like there isn't much else delaying him flying to us, so.
Do a gastric tube and do we want to check
So it
this?
looks like we've got good expansion there.
Do the remaining assessment? Okay. So if you're on airway, do you want to run C-spine and we'll check his back?
Sure.
You want to roll to the left away from the chest tube?
And I think we are on the vent now.
Okay.
I'll have to
Archie's here.
weird.
Dr. Payton, you've been pretty quiet on me these last handful of minutes. Is there anything else you're needing, or what?
No,
What
right.
are your thoughts right now? What else are you seeing?
So right now he's vitally stable. He's got a few small superficial lacerations. He has some abrasions. He has a hematoma on his abdomen. It's over the left,
Head to toe.
but his abdomen is still soft at the moment. We're gonna roll to the back, see if there's any trauma to his back at the moment.
His neck first.
Great.
Check in the front of his neck. There's no JVD or tracheal deviation noted. No subacute air. That's the collar back on. Okay.
All right, we're ready to roll. On my count, nice and easy. All the way up. Ready? 1, 2, 3.
Good.
Go ahead and pull
Check
that shirt
back.
and get all that stuff.
There is a hematoma to his mid-back, right about the L1 to 2 range. Beyond that, there's no other trauma. There's no step-offs there that I can feel. No blood coming out of his rectum at all.
Okay.
He's good.
Back
Roll
down.
back.
1, 2, 3. Secure all the straps.
Okay.
again.
Securing for transport.
Great, guys. So the plan will be for him to come directly to our trauma bay. We will make him a level 1 trauma alert, with the plan being that as soon as he gets here, we'll do another just very quick primary survey, and then he'll go straight to the CT scanner. Since I've gotten a good look at him here over the video conference, plan will be to kind of work up the rest of his injuries once he gets here. In terms of in-flight, if he's going to need more sedation, I think that fentanyl has been working well for him, so we'll continue that at a 35 microgram boluses. And then flight, if they have any questions at all, we can work out ventilator settings en route. And he's got his fluid bolus, his blood, his TXA, and he's otherwise doing really well at this point. What else can I do for you guys?
Hurry up the helicopter.
All right, it's on its way, I think.
Trauma team pause. At this point, the flight team has arrived. We'll package the patient and transport them for regional trauma center evaluation. We'd like to review the clinical scenario, and we'll start with our trauma provider, Dr. Payton. Like your input as to how that felt and how you felt having Dr. Lammers assist during this situation.
I was very glad to have Dr. Lammers assist me during that situation. I will be honest, I haven't done a whole lot of chest tube placements, nor have I done a lot of RSI, so because of that, it was very good to have his input on that and the order in which to do it, which was great. Beyond that, I think the team worked incredibly well together. They kept
Nurses,
me
do you have any
informed.
input? Darcy or Brent?
I think it went pretty well.
It's something we do frequently, but kids are always super stressful, and there's nothing worse than being out in the field or even in the ER and having difficulty with an airway to increase your stress level just right through the roof. This is not nearly messy enough for a real trauma. There should be mountains of stuff on the floor.
And Dr. Lammers, we'd love your feedback as well.
Yeah, no, I mean, these are, we kind of talked about this as we were going through the prep for all this. You know, during my residency, every week we would do cases just like this where things were video recorded. It went like in your permanent file the rest of the residency, and all the attendings were looking on the other side. It was super stressful. So, you know, Dr. Payton, you got thrown into this, and these are like crazy stressful, and you did an awesome job. Yeah, I know you're looking at going into to do emergency medicine, and being at a smaller outlying facility, these patients show up like this 100%. I mean, it's like you can just plan on this happening to you and having the limited resources and all of that. So I think you did lots of things really well. Staying calm and level-headed. I loved your initial presentation to me. Sometimes when things are crazy and you get your other provider and you want to jump right to, you know, I think he's got a tension pneumo and his belly's this, but you did a great job of, this is what I have, and it's like we've worked on in the emergency department here, that you've got those 20 seconds that is my attention span, that you gave me everything that I needed, and you honed in right on what needed to happen. I think that the communication was really good. I think as you started to get a little bit more quiet, it's because, and I know why you're quiet, because you're doing your thing and you're working through all this, but the rest of us may not know that. And so I think just verbalizing, you know, what you're thinking, it helps you talk through what you're doing, but it also helps the rest of the team know that you know what you're doing as well, because otherwise we may not know. For me as the provider on this end, it was good to hear the repeat vital signs. That's sometimes things that can go 10 minutes without hearing repeat vital signs, and all of a sudden things are really in the toilet, where maybe we would have known a slowed down trend that we could have addressed sooner. So that I thought was really good. In terms of the interaction through the video, I think that went well. it's nice that there's the iPads on that end because they are a little bit more mobile. So you can switch me around so I can see what you're doing and provided help if I would have needed to. But you did great on both procedures, and yeah, honestly, I think from a critique standpoint, overall, I have very little to need to critique. So.
Thank you. I'd like to thank our trauma team. Trauma care requires a team approach. Frequent practice. So we really appreciate our nurses and EMS team and Dr. Payton. And thank you, Dr. Lammers. We will.
Yeah, you're welcome. No, it's my pleasure.
Awesome. Thank you so much. We'll disconnect with our iPad at this time, but as you can see, this is a really small footprint, and I think is an advantage for.
There's a lot of people there.
There's a lot of people there.
I wasn't expecting that many people.
Absolutely. So,
Okay.
thank you,
Thanks,
Dr.
everybody. I
Lammers.
appreciate it.
You bet. We'll let him go so he doesn't have to listen to me. We think telehealth services provide great opportunities for improving patient care across Montana, specifically in outlying areas and in rural areas where perhaps a locum providers come in and they're not familiar with your system or your team, and they don't know what resources you have, or maybe they've decided to moonlight a little bit and they haven't done a chest tube for a long time, if ever. It's really nice to have that person on the other end that's comfortable with that skill base and can help that provider walk through that. I used to fly, and I can tell you I came into situations and I would feel for those providers in those areas, because you have to be able to deliver a high-risk baby, you have to be able to intubate a trauma patient, you have to be able to do everything, and people expect you to be perfect at it or excellent at it. Their lives are reliant upon it. So I think this is an excellent resource for gaining a specialist, whether it's a pediatric intensivist, an ER physician, or a neurologist, to give you that insight and help to get through those difficult situations. We hope that this can better package patients for interfacility transfers. We hope it can avoid unnecessary transfers, so you can keep some of those patients in your facilities and they can get appropriate care close to home. Because sometimes they don't need to go, but you're just not sure. And this gives us the ability to look at the patient, to give the provider guidance, so that maybe that patient doesn't need to transfer out. And what does that translate to? Cost saving, which we all care about these days. So those are very important points that telemedicine and telehealth can gain for us. I think consider this the next time you have an emergency, and as a resource to your patients. I think we need to increase use of it. It helps with skills, it helps with medical decision making. Another thing we talk about is Montana weather can be pretty unpredictable. We have instances where flight teams or ground transport cannot get out, and you have a patient that's weather bound or stuck at your facility. How great would it be to say, I've done these things to this patient, I'm not going to be able to transport them out. And we had a pretty cold winter last winter. What can I do next? What's the next course of action for this patient? I'm going to get them to the next level of care as soon as I can, but in this critical time, what can I do for this patient? And lastly, we think it can be used as a great training platform, as we've shown today, for healthcare providers to do simulated scenarios. And high acuity situations, they come when we least expect them, and so we need to practice. And practice is essential to being on top of our game and providing the best care. And the use of emergency telemedicine, it's a shift in how we think, right? Usually we just pick up the phone and we call. We call those facilities that we transfer to, but this is another tool that we have, so we have to think about using it. And it's this mobile little cart. We just have to pull it out, not put it in the corner, but pull it out and use it and think about using it just like we would a telephone call. The process is really as seamless and simple as it is a telephone call. So I think it's just a change in thinking and a new way of doing things.